My name is Dr. Chaitya Desai, and I'm an FYY at Birmingham City Hospital. I'm going to be talking about colorectal cancer. So, colorectal cancer, or CRC, is the third most common cause of cancer in the UK and has the second highest mortality of any cancer. Its occurrence is strongly associated with age, but it can occur in patients as young as 20 years old due to inherited cancer syndromes, which I'll be talking about later. The median age of diagnosis is approximately 70 in the UK, and 59% of cases occur in men. By the end of this PowerPoint presentation, this lecture, I hope that all of you are able to understand the etiology of CRC, recognize its clinical features, understand key investigations in diagnosing it and staging it, and the management options based on an MDT approach. In terms of etiology, colorectal cancer can be defined as a malignant neoplasm arising from epithelial cells anywhere in the large bowel. This excludes the appendix and excludes the anus. Most colorectal cancers develop via progression of normal mucosa to colonic adenoma via a process of hyperproliferation, and then through a process of dysplasia, they become invasive adenocarcinomas. Adenomas may be present for over 10 years before they become malignant, and progression to adenocarcinoma occurs in roughly 10% of adenomas. Certain genetic mutations can predispose individuals to CRC. The first one I'd like to talk about is an autosomal dominant mutation in the tumor suppressor gene APC, adenomatous polyposis coli. Mutation of this gene results in growth of adenomatous tissue associated with the condition familial adenomatous polyposis. So with FAP, patients will present in early childhood with colonic polyps, which then become adenocarcinomas as the patients enter their 40s. And around 90% of patients with FAP develop adenocarcinoma in their 40s. The second gene mutation is a mutation to the HNPCC gene, a DNA mismatch repair gene. And actually, this is a collection of genes rather than one singular gene. But it leads to defects in DNA repair, and it's associated with Lynch syndrome. Lynch syndrome also causes ovarian and endometrial cancers. In terms of risk factors, there are a few risk factors which increase the chance of CRC, and demographically this include increasing age, family history, a previous history of cancer, inflammatory bowel disease. So it's really important to ask about ulcerative colitis and Crohn's when taking a history for a patient that you suspect has CRC. It's important to note the extent and the duration of the colitis. There's also certain modifiable risk factors, such as a low-fiber diet, high processed meat intake, smoking, and alcohol. So, in terms of clinical features, they're variable and they depend on the site of the tumor. Symptoms from a primary tumor include iron deficiency anemia, altered bowel habit, and this can be anywhere to an increase of loose stool, or bowel obstruction and bowels not opening. There's also a chance of abdominal pain developing, blood being noticed, particularly in the distal part. If the tumor is located in the distal part of the colon, you may see rectal bleeding. And tenesmus, which is a sensation of incomplete defecation that's again associated with the distal part of the colon, so a tumor in the rectal region. Tumors in the right side of the colon, so in the ascending colon, the cecum, are often presenting at a more advanced stage with symptoms of weight loss and anemia, as they don't have these very obvious features on presentation. And in fact, some individuals may have no clinical features and may simply be diagnosed with CRC based on a screening test. So, NICE guidance recommends that patients should be referred for urgent investigation on the 2-week wait pathway of suspected bowel cancer if they have any of the following, and this is split out based on age groups. So 40 years or above with unexplained weight loss and abdominal pain, 50 years or above with unexplained rectal bleeding, 60 years or above with iron deficiency anemia or change in bowel habit, and finally, a positive fecal occult blood test at any age. So a fecal occult blood test essentially is used to measure the presence of blood in stool, which cannot be seen by a visual inspection. It's also important to note that iron deficiency anemia on its own, without any other explanation, i.e. no presence of heavy menstruation, etc., is an indication for 2-week wait cancer referral for colonoscopy and OGD, so top and tail for GI malignancy. And this is because GI malignancies can cause microscopic bleeding, which is not visible on stools, and this may eventually lead to iron deficiency anemia. So, the CRC screening program. So in the UK, between the ages of 50 and 74, every 2 years, a fecal immunochemistry test is done. This is a very sensitive and specific method of detecting human hemoglobin compared to traditional chemical methods, where other types of hemoglobin would also be measured in the stool and thus giving false positive results. So yeah, an FIT test between 50 and 74 every 2 years. At the age of 55, a single flexible sigmoidoscopy is offered, and in the event of a positive FIT test or anything of note on flexible sigmoidoscopy, a colonoscopy may also be indicated with further investigations in the form of bloods, imaging, etc. In terms of bloods, full blood count may show microcytic anemia. CEA, carcinoembryonic antigen. It's not used as a diagnostic test, but it's used to monitor disease progression, pre and post treatment, and also screening for recurrence. It's a very good cancer tumor marker in that way. A gold standard for diagnosing CRC is via colonoscopy plus biopsy. A colonoscopy will obviously visualize any lesions in the colon, and a biopsy will be used to stage the level of dysplasia. A flexible sigmoidoscopy can also be performed if there are certain comorbidities such as frailty or there's a patient intolerance for colonoscopy. In terms of staging, CT scan, particularly a CT TAP, CT thorax, abdomen, pelvis, is very useful for looking at distant metastases and local invasion. A full colonoscopy or CT colonogram is required to check for a second synchronous tumor, if not used initially. For rectal tumors, an MRI rectum or an endoanal ultrasound can be used to look at the depth of invasion and also the need for either preoperative chemo or suitability for a transanal resection. Staging can be done using the TNM system. The TNM system looks at 3 factors. The T stage is the depth the tumor invades the bowel wall. The N stage is the evident extent of spread to local lymph nodes. And the M stage, which is simply a yes or no, is whether or not there are distant metastases. So, hypothetically, if we're looking at this diagram here, and we've got a T1 staging, this just means that it invades to the submucosa, whereas T4 invades to the visceral peritoneum. N0 or N2 depends on the number of regional lymph nodes, and M0 or M1 is a yes or no based on whether there's distant metastases. This replaced the pre-existing Duke staging system, which is still useful for exams and to stage certain CRCs. So the Duke staging system is basically an A to D system, looking at whether it's confined beneath the muscularis propria or whether the lesion extends through the muscularis propria, or there's involvement of regional lymph nodes or distant metastases. The higher the stage, the lower the 5-year survival. Management. A management decision should be undertaken by an MDT, and this is based on the clinical condition of the patient, general health, staging, radiography, histology, and ultimately the patient's wishes. The only definitive curative option is surgery. However, chemotherapy and radiotherapy have an important role as neoadjuvant, so pre-surgery, or adjuvant treatments, i.e. post-surgery, and also they have a role in palliation. So with this slide, I just want to highlight how important the vasculature and the lymphatic supply, lymphatic drainage of the bowel is. So, for example, if you have a lesion here, a tumor, there is scope for it to locally invade further distal to the colon, or locally, so has the option to locally invade further distal to the colon, proximal to the colon, or just all any way around the colon wall itself, or it may spread to the lymphatic regional lymph nodes here, maybe more distal lymph nodes, or it can even spread to the vasculature. Now, this is important because when you're performing any curative procedure, the margins of resection need to be a lot larger than what you normally expect. So it's not enough just to take out a local core biopsy of the tumor itself. Instead, you need to ensure there's enough of a margin so any surrounding lymph nodes or vasculature which may be affected are also removed. In terms of surgery, laparoscopic approaches give better recovery and fewer complications. It doesn't mean they're better than traditional open surgeries, because ultimately the end result is the same. There may be better recovery times, and this may be better for the patient on a patient-to-patient basis. Now, the general plan is a regional colectomy. So this is the removal of a primary tumor with, as I said, adequate margins and lymphatic drainage, followed either by primary anastomosis or formation of a stoma. In terms of the anastomosis, it will be an end-to-end anastomosis. So you chop out the bit of bowel that has the lesion or the tumor, and you sew the remaining bits together. Now, depending on whether it happens on the right side of the bowel or the left side, it's called either a right hemicolectomy or a left hemicolectomy. So here we've just got a little example. So there's a lesion here in the ascending colon. So instead of just that little section of tumor being removed, it's actually the majority of the ascending colon and the cecum which is removed. And now there's two options at this point. So you can either join the end of the small intestine to this part of the colon, or you could bring it out as a stoma, as an ileostomy, and leave this area for bowel rest, and then eventually form the end-to-end anastomosis. With the right and left hemicolectomy, there are certain vessels and lymph supply which will have to be removed alongside the area where the tumor has affected the colon. So for the right hemicolectomy, the ileocolic, right branch of the middle colic are divided and removed with their mesenteries. And with the left hemicolectomy, it's the left branch of the middle colic, inferior mesenteric vein, left colic vessels, and these are divided and removed with their mesenteries. So, other things to know. If there's a tumor in the sigmoid colon, a sigmoid colectomy is performed. In this procedure, the IMA, the inferior mesenteric artery, is fully dissected out with the tumor to ensure adequate margins are obtained. The other procedure to note is an abdominal perineal resection. So this is performed for tumors which are lower down, more distal, in the sigmoid or rectal region. They're quite extensive and need more than just a sigmoid colectomy. This involves removal of the sigmoid colon, rectum, and anus, and essentially the patient will need a permanent colostomy. With any surgery, there are complications, and these complications are important to be aware of, that the patient makes an informed decision before undergoing the surgery. The main ones with these bowel surgeries to be aware of is an anastomotic leak, which occurs 7 to 10 days post-surgery, and is particularly higher risk in lower anastomoses, such as in something like a sigmoid colectomy, for example. The anastomotic leak may present as the patient having peritonitis and then undergoing sepsis. Other things to be aware of are strictures, obstruction, injury to urinary tract, which is very closely associated with these structures, and particularly with AP resection, so the abdominal perineal resection, is sexual dysfunction, because this can be as a result of injury to nervi epigentis, which is a nerve supplying that area of the urinary tract. Failure of ejaculation may also occur due to damage to presacral nerves, and dyspareunia in women due to fibrosis around the vagina. Following AP resection and the removal of the muscles involved in defecation, some patients may have an uncomfortable sensation of a rectum, which they aren't able to control, called a phantom rectum. There's also complications with stomas themselves, such as infection to the actual stoma site, leading to skin infections. A surgery which is not commonly used for CRC, but can be an appropriate option, particularly if it's an emergency bowel surgery, or if a patient is too frail or elderly to undergo a longer procedure such as an AP resection, is the Hartmann procedure. So Hartmann's procedure involves a complete resection of the rectosigmoid colon, so removal of this area, and the formation of an end colostomy, which comes out, and a closure of the rectal stump, Hartmann's pouch. So this is not going to be functioning. It's just left there. The colostomy is brought out. As I mentioned, chemotherapy has an important role in not as a curative primary management option, but it can be used particularly to reduce mortality as an adjuvant therapy. So following the process of surgery, if there is any chance of metastases, chemotherapy is a good option to reduce mortality. A common chemotherapy regime can be remembered as FOLFOX, so folinic acid, fluorouracil, and oxaliplatin. It's been demonstrated to reduce and significantly improve 3-year disease-free survival for patients with advanced colon cancer. So we've talked about chemo and it's using adjuvant therapy. Now let's talk about radiotherapy and it's using neoadjuvant therapy. So radiotherapy can be used in rectal cancer, particularly to shrink the tumor so that then the surgical procedure can be done appropriately with adequate margins and ensure a curative resection. Very, very advanced colorectal cancers may not be appropriately managed surgically. And again, this is also dependent on patient demographics, wishes. But palliative care is a key part in ensuring that there is a management plan for these patients. And these palliative approaches focus on reducing cancer growth and symptom control. So endoluminal stenting can be used to relieve acute bowel obstruction in patients with left-sided tumors. This stent works very similarly to any other stent in the body and is very important to prevent obstruction. Main side effects may include perforation, migration, and incontinence. Stomas can also be used, particularly in patients with acute obstruction, usually with either a defunctioning stoma or palliative bypass. And there's also an option for resection of secondaries, which is not commonly performed but can be done with adjuvant chemotherapy for any liver mets. Just want to finish off with a case. So in this case, we have Mr. B, a 45-year-old man who's presented with rectal bleeding of 4 months duration. Examination demonstrates a mass 7 centimeters above the anal verge, and biopsy confirms adenocarcinoma. It's important in terms of distance above the anal verge because it determines the surgical management that you choose. So, for example, if it's less than 6 centimeters above the anal verge, then you'd have to undergo an AP resection. Now, going back to the case. So what important staging information is required before an appropriate treatment plan can be developed? So it's important to note that the extent of the disease needs to be established. Now, this may be through imaging, and a CT scan of the thorax, abdomen, and pelvis would be appropriate. Once you've understood the staging information, and we assume that he has a localized tumor, what would the recommended treatment be? So, if the staging shows the tumor is confined to the bowel wall, then a resection should be carried out. If there is any chance of metastases, then preoperative chemoradiotherapy prior to surgical resection would be the best option. So a neoadjuvant start and then the surgical option. And how would you follow up Mr. B's care in the event of a complete response? So that's where CEA levels can be useful in surveilling, and also routine every 2 years doing a CT tap to just ensure there's no metastases, as well as colonoscopies can be used, and these are based on local guidance. So that's the end of the slideshow. Thank you so much for listening. If there are any questions, feel free to email me, and